About capillary flux again. And what I'd like to do is do a little bit more applied version of this now that we're in the cardiovascular section of the course. If you recall, when we talked about fluid compartments earlier on, I did do a video that covered sort of the very basics of diffusive and bulk flux, so you might want to go watch that one first. It's a capillary flux, capillary exchange video. But now I want to do it, so I'm going to reiterate some of the things in that video, but I want to add in some more specifics so we can start to apply changes to the, to some of the parameters here to see what changes essentially. And to do that, we need a little bit more information than I gave you previously. So what I'm going to do is I want to draw a really schematic capillary here, a capillary bed, I guess. And so put it over here. And I tend to draw this sort of as an H, which you've probably seen before if you're looking at my chapters. Right? So this is a capillary bed that literally has a single capillary in it. Okay, and so this would be the arterial, right? Small artery. And it would have actually smooth muscle on it. I'm being very schematic here with the structure of this, right? So there'd be, add some layers of cells to this. Right? There'd be smooth muscle on this guy. Whereas on the capillary does not possess smooth muscle. It's just an endothelial layer in the basement membrane. That makes this the capillary, right, in between. And again, there wouldn't be one, there would be numerous. And this is a small vein, also known as a venule. Right, so arterial on one side, the inflow end, right, so our flow is going this way. And then off into this venule or system of venules. They're going to carry blood back to the heart. Okay, now when we discussed this previously, we mentioned that there are two forms of exchange across the capillary wall. In other words, between the ISF, interstitial fluid, and the plasma. Right? And I haven't even drawn any red blood cells. We can add one here if you'd like. Right? They're obviously a really critical component of the circulatory system, but they're not the focus of what we're talking about right now. Right? But let's not forget that they're there. Right? And so we're talking about exchange between the ISF and the plasma. Okay, and of course, let's not forget that the reason we have capillaries out here is they're adaptive to exchanging with our tissues where our cells are found, right? So we would have cells out here, and maybe even more complete, right? We have what's known as a lymphatic vessel, sort of in many tissues, that would pick up excess interstitial fluid. As it's being produced, right, sort of flow would be out of this guy and end up actually back in the bloodstream. I'm not trying to make this blood capillary and this venule look like they're connected. They are not. Okay, and of course that would contain lymph, right? Lymph is the interstitial fluid that's being picked up and carried within lymph vessels back to the blood. All right, we covered all that in that previous video. All right, the two forms of exchange across the capillary wall are diffusive flux, right? We had previously defined this as J-diff, and it kind of depended on whether we were talking about, not kind of, it totally depended upon whether we're talking about a lipophilic solute or a hydrophilic solute, right? So J-diff for a lipophilic solute equals negative dA lambda times delta C over delta X. And again, you don't like the equation, that's fine. But you do have to understand the factors that affect diffusion, which are all included here. Just as a quick reminder, the diffusion coefficient contained things like the size of the molecule, the temperature, things diffuse faster at a higher temperature, The viscosity of the fluid, right? Things would diffuse slower through a very viscous solution. So those are factors that are all sort of lumped into the D, diffusion coefficient. The surface area is the surface area available for diffusion to occur across, right? So we have a single capillary here that has a certain amount of surface area, right? So that would be the surface area we're talking about here. If there was a second capillary, right, we would have double the surface area for diffusion in this particular region. Lambda was the lipid solubility, and again, that matters for lipophilic solutes, right, and those that are partially lipophilic, right? Now, a hydrophilic solute, right, one that is water permeable but not fat permeable, lambda would be 0, in which case your diffusion, right, would be 0. So if we want to talk about diffusion across cell membranes of a hydrophilic solute, that would be 0 unless we have a pathway provided, right? It can't go through the lipid bilayer. Lambda would be 0. Delta C is our concentration gradient, right? So the bigger the gradient, the greater our diffusion rate. And delta X is our distance, right? If I add a cell, that's a little farther away over here, right? This distance is greater than this distance, right? And so diffusion rate to, this first cell right here, this cell, would be faster than the diffusion rate to this second cell I have over here. And again, that would be because the distance is greater to cell B here than cell A, right? And if the distance is greater, then the diffusion is slower, right? Inversely proportional. Now, okay, so this equation is for lipophilic, right? Put lipo here. If the solute is hydrophilic, and I know diffusion can be confusing, but really it's more about the basics, right? We're not going to, again, don't get bogged down in the equation and, the ugliness of don't memorize the equation. Understand how those elements in it would affect diffusion, and they're quite logical, right? If there's more surface area, there's greater diffusion. If there's a bigger gradient, there's greater diffusion. The gradient drives the diffusion, right? If the distance is greater, then the diffusion would be less, right? It's got farther to go. It all makes sense, right? Now, one element that does make it a little bit more complicated is if we have a hydrophilic solute, it can't go through the membranes, right? So we'd have to have a slightly different equation, and it's very slightly different. So we're going to put in a variable here, P, instead of lambda, right? Remember, if it's hydrophilic, then lambda is 0, right? And in which case it can't go through the cells, right? So we have to have a different pathway here. So we'll get to that in a second. The rest of the equations exactly the same, right? And this would be for hydro. Again, lipophilic. I'm just running out of room here. Lipophilic and hydrophilic. Okay. So for hydrophilic solute, our pathway, and maybe I want to add a little bit of detail in one spot here. Our pathway for a hydrophilic solute, I'm going to draw 2 different cells here of the capillary wall. The pathway would be here, right? Depending upon what the gradient is, it's going to determine our direction. So I'm just going to put arrows in either direction. But the idea here is that it's not going through the lipid bilayer, right? It's not going through the cells. It's going through a gap between the cells. It's an endothelial pore. And so that's where this P comes in, right? This P is permeability. Across epithelial or endothelial, same thing, epithelial pores, right? The gaps here. And so, right, so if the solute, well, let's use a good example here. If we're going to talk about a protein, right? If we're talking about a protein, a plasma protein, so here it is, right? Its permeability across most capillaries is 0. And remember the reflection coefficient? The reflection coefficient is basically P, right? P is more generic. But it's the same idea. So our permeability here, right? If it's a protein, in most capillaries, it's not permeable, so P would be 0. So diffusion of proteins, from plasma to interstitium would be 0. What about sodium? Sodium is very much smaller than a protein, and so P would be very high. And again, as long as we had a gradient and other things were favorable, then the diffusion could be quite high, right? So again, permeability, if we're going through an aqueous pathway across the capillary wall, we're going to use lambda. If we're going through the cell membranes, we're going through a non-aqueous, right, a fatty, if you will, pathway through the membranes. Okay, and those two equations will help us describe the diffusion of solutes in and out of the capillaries. And that is how a lot of stuff moves, right? Oxygen, CO2, largely move by diffusion. Glucose largely moves by diffusion. However, again, in that previous video, we also talked about bulk flux, right? And we gave the term J bulk. And we talked about how it was related to both hydrostatic and osmotic or oncotic, because we're talking about big solutes here, proteins, pressures. So, fluid movement across the cell membrane was all driven by osmosis, right? Osmotic pressure gradient. Whereas across the capillary, we have two types of forces that are acting on it. We have that osmotic and osmotic pressure gradient due to the trapped proteins. Let me add those guys in here. Right here are my proteins, trapped plasma proteins. They are much greater concentration than the fused soluble interstitial proteins I have, right? So only a couple of them out there, but a higher concentration in here. And we have a standing plasma or blood oncotic pressure that's pretty high, right? Now, we can't just say, okay, that's it. That's going to draw water into the cell, right? Remember, water tends to move toward a greater solute concentration. That's true. But so it would sound like, if that was the end of the story, that water would just be flooding into the plasma from the interstitial fluid endlessly. Well, that doesn't happen. In fact, it's actually the opposite direction, and that's because we have to account for the hydrostatic pressure. So we have to give you this thing called the Starling equation. So the J bulk equation is the Starling equation. Starling. Right? And what we get here is J bulk equals, it's a little ugly, and again, we're not going to literally use the equation, but it does lump together the factors that we need to understand bulk flux. Okay, and so we've got this variable called Kf, and then we're going to multiply that by the sum of our hydrostatic and oncotic pressures, right? And so, well, the difference between, I should say. And so we're going to, I'll give you the meaning of these in a minute. So we have our two hydrostatic pressures, which is really 1, because 1 tends to be very close to 0 most of the time. And then we're going to have our oncotic pressures, and we use the symbol pi for that. Right, and actually Kf is multiplied by this whole thing. So we're going to put brackets around the whole thing. Right? So Kf is our leakiness coefficient. Right, that's probably my term for it. Okay, and it includes things like the water permeability and the surface area, right? So, but a measurement of its leakiness, right? How readily water in small solutes, remember, big ones don't move in most capillaries, but how readily water in small solutes can move, based upon the structure of the wall alone. But remember, it's not just how leaky it is. It's like, well, what's the pressure driving it across that leakiness? And that's all the rest of this over here, right? And that is, so these are the hydrostatic pressures here, HP, right? Both of them. And these are the oncotic pressures here, OP. Okay? So the C is for capillary and the I is for interstitium. So PC, let me clear some space over here. PC is the capillary hydrostatic pressure, and it would be pushing outward, right? It is a filtrative force. Let's put a little F under it here for filtration, right? It drives filtration always. PI would be the hydrostatic pressure of the interstitial fluid. There's fluid out here, so it has the potential to have a hydrostatic pressure, right? Well, the good news is it tends to be very close to zero, so we can ignore it, right? It's not always zero, and we may throw a scenario at you where it's not zero, and then we can talk about it, right? And so I'm not really going to put a filtrative or reabsorptive label on it here like I did for the blood hydrostatic pressure, because it tends to be zero, in which case it's it's neither, right? Okay, so the pi c is the oncotic pressure of the inside the capillary, right? Again, that's due to these green proteins, and so pi c, label this right here. Pi c is due to those proteins, and which way is that pulling? Inward, right? It's pulling toward the solute. Okay, so that makes that a reabsorptive force. I'm going to put reabsorptive on that guy. All right, so that's going to be an opposing force for filtration. Okay, now the last one here is pi I. And pi I is pressure due to these guys out here, right? That protein. That's pi I. Well, that's tending to pull water outward, right? Because it's a solute on the outside. So that is also a filtrative force. So we really have two filtrative forces and one reabsorptive force, right? Okay, well, to figure out how much is moving, how much water in small solute is moving, in response to these pressures, we could just graph it basically, right? And so the one thing, and again we talked about this previously, is if we graph the hydrostatic pressure from the inflow end to the outflow end, it falls. Right? Remember, that's absolutely true in all pipes, right? As fluid flows through a pipe, its pressure falls due to friction with the walls, right? A loss of energy. And so that force, right, is going to go down, 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 right, as we move from this end over to this end. So the arterial end and then the venous end over here. So that pressure is falling. And I'm not giving you the actual numbers for these pressures. They're measured in millimeters of mercury. I don't care, right? It's the relative magnitude of them that's more important, because then we can assess, what are these pressures? How are they? Who's winning essentially, right? And so we already had said a minute ago that this is this red line I just drew is a filtrative force, right? Here it is. It's a filtrative force. We don't have to put a pi I on there. We could actually call this line the net hydrostatic pressure, because the other one's zero. Okay. Now we go over here. Pi I tends to be really small. Yes, it's filtrative. It tends to be really small. So again, we could call the other line I'm going to draw here either pi c or net oncotic pressure. Again, under most circumstances. Right. So let's label this first guy we'll label it as net, just to be sort of inclusive in case the interstitial pressure is not zero. We'll call it net hydrostatic pressure. Now what we'll do is we'll call the other one the net oncotic pressure. And it sits about here. That's the net oncotic pressure. All right? So check it out. Remember, this is a filtrative force up here. This is a reabsorptive force here. So which one's winning, right? We can put a scale over here if you like, right, with numbers on it, right? There's a measure of those forces, but the filtrative force is greater. So guess what? You get filtration, 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 and it's not an enormous amount of filtration, but it's winning end to end, right? Here, right there, they become about equal, and you would stop filtering, Okay? So that is basically the bulk flux description of a perfused capillary. Here's the tricky bit. Many capillaries are not perfused at a given instant, and actually they alternate sort of back and forth. Let me get that out of the way. Right? So in other words, that we're going to draw another capillary down here. Where am I going to draw it? I'm going to move it over here where I have a little bit more room. So I'm going to draw another capillary, but this one's going to be, the arterial is going to be constricted. Right? I'm going to shrink it a little bit so I have room. So this capillary is, arterial is constricted. And I think we did this again in the previous video, right? Here's our smooth muscle. Now our smooth muscle is all sort of bunched up because it's contracted. Oh, we could come back to Poiseuille's law if you like, right? If this is constricted, right, the radius got smaller. The radius gets smaller, the resistance goes up. Okay, let's put it on here, put Poiseuille's on here. Q equals the pressure gradient, delta P over R. Right? So if the resistance goes up dramatically because we're squeezing it here, it's constricted, right? This resistance is increasing. If that's increasing, what's happening to Q? Remember, Q is flow, right? If that resistance is rising, if pressure's the same, then Q is going down, right? And so we end up with capillaries that are unperfused. And remember, this is what capillaries do. They go back and forth between, the one I have up, A up here, right, looking like this, or B down here, right, looking constricted, and therefore the flow through this capillary could be low or zero. All right, well, that doesn't affect the protein concentration here. The proteins are still here. Here they are, sitting there with their generating their pi c, right? That's our primary reabsorptive force. They're pulling inward. Right? But what happened to our hydrostat? What happened to PC? Right? Here's our PC. What happened to it? If we constricted this vessel and there's no flow in this capillary, then PC fell dramatically. All right. Well, remember, PC is the primary component of our net hydrostatic pressure. So let's regraph our pressures. Right? Now our pressures are going to look like this. Our hydrostatic pressure is still going to do like it. Let's assume there's still some flow here, right? It's not zero flow. But as we move across, right, our pressure is still going to fall. So here's our net hydrostatic pressure, right, falling. But remember, it started lower here, right? It started lower. Over here, that spot right here would be down here, right? So, right, because it's a much lower pressure because in this capillary, in the B capillary, it's not being perfused. So that pressure has fallen because it's not perfused, right? We dropped this line down. But I just said a minute ago that pi c, right? I have it labeled inside, so I should put that label back inside again. Pi c, right? But that inward force, right, due to those trapped proteins, hasn't really changed. So it looks like this. And again, that's our net oncotic pressure, again, which is largely pi c. And here's our net hydrostatic again. Oop, net hydrostatic pressure. So, check it out, right? This is a reabsorptive force. This is our filtrative force, the one that just dramatically fell. So now what's happening as we move through our capillary? Reabsorption, 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 right? And so in reality, what happened is if you put this capillary A right next to capillary B, right? Capillary A is filtering, right? And capillary B is taking up what capillary A just filtered, right? It's returning it. So even though filtration dominates in our perfused capillaries, we don't end up with this sort of large amount of interstitial fluid because much of it, right, this filtrate right here, is going into here, right? Into an adjacent unperfused capillary constantly. And actually, remember, A and B can flip-flop. B will become A and A will become B, right? A will constrict and B will dilate. That's what capillaries do. They alternate between constricted and dilated. And so, but what I'm getting at here is that, so we filter in perfused, we reabsorb, right, in unperfused, and any excess, right, and there is excess produced, will end up being taken up by, you guessed it, lymph, the lymph vessels, right? And of course, that is returned right back to blood, right? The lymph vessels coalesce and attach to veins up in your upper chest and return that excess interstitial fluid, which came from the plasma, right back to the plasma, right? The lymph in between. And there you have capillary exchange with probably more detail than you like, but now we can talk about, right? Now we know the individual forces. Now we can apply things, right? So let's just do one or two just to get a handle on what this might look like, right? So I'm going to make some room. Right? And we could draw things, or we can just talk about it sort of figuratively. So, but let's give a scenario here. Let's say somebody has hypertension, right? If somebody has hypertension is high blood pressure. Which of these forces is modified? Initially modified. There might be downstream effects, but the primary force affected is which? Blood hydrostatic pressure is PC, right? Hypertension, right? Your blood pressure is a measure of blood hydrostatic pressure. So PC would be the one that is higher than normal. Let's put a line over here, right? So now we've gone to our filtering capillary, but look, our red line is no longer here. Now let's put it, draw a straight line here. Right? I put it bumped upward, right? That's hypertension, right? So our red line would be normotension, normal blood pressure, and the purple dashed line above it would be hypertension. What just happened to filtration? You got it. The filtrative force is winning by more, and so filtration, right, increases, right? Now, so that means there's more lymph flow. It also means that fluid could accumulate if the lymph flow can't keep up. Fluid could accumulate in the interstitial spaces and lead to what's called edema. Right? So if we get this excess filtration, do we get edema? Right? Maybe. Right? Again, if lymph flow can't keep up, edema is that interstitial swelling, right, that we would get if we had excess fluid there. It is a common side effect of severe, at least severe hypertension. Okay, let's do one more, right? And the whole idea here is to sort of be able to look at these individual Starling forces and sort of assess, like, okay, well, if I changed one, what would happen to the the filtration or the reabsorption? What happens to lymph flow? All that kind of stuff, because it's really important. These things happen in a lot of people, a lot of patients, right, that have these issues. So let's look at, let's do liver failure. We keep going here with others. And by the way, before we go on, what if you did hypotension, right? Just throw a purple line on over here, throw it on lower than the original red line, and what happens? Uh-oh, filtration falls, and you might even start to get some reabsorption, right? So you get less lymph production and less fluid in the interstitium, right? But let's tweak one on this side of the equation over here in the oncotic pressure. Let's do liver failure. Do this as our last one here. Okay. Well, how's liver failure related to any of this? Well, the liver produces the majority of the plasma proteins, right? The plasma proteins are generating our pi c, our primary reabsorptive force, right? So we could, want to sort of schematically show you what's happening right here. We would have to remove some of our proteins from the plasma, right? So our pi c would fall. And now we'd have to draw a new line for the net onconic pressure, right? The net onconic pressure would have fallen, right? Because now we're not affecting blood pressure with this change. We're affecting the concentration of the proteins. And so we've gone from normal down to here. Now look at the difference between the red line, the filtrative forces, and the reabsorptive forces, right? The reabsorptive force fell. Look at the difference now. The difference got bigger again, right? Hypertension made the difference bigger, but because the red line went up, became the purple line. Whereas in liver failure, the difference between the hydrostatic pressures and onconic pressure gets bigger because the onconic pressure falls, right? And so now we would get, right, you're going to get decreased reabsorption. And decreased reabsorption really means, therefore, right, our little symbol for therefore increased filtration, right, and possible edema. Really common in liver failure patients is what's called pitting edema. And it's called pitting edema because if you push your finger in on there, usually occurs most in the lower extremities, again, because of gravity, sort of fluids collecting down in the lower extremities. If you push on their leg, right, makes a dent. You sort of squish the interstitial fluid out of the way. You pull your finger away, and it leaves a dent there. That's why it's called pitting edema. Now, does it fill back in with fluid, the interstitial fluid over time? Sure. But the fact that you can sort of squish fluid out of the way like it's in a sponge suggests that there's a dramatic amount of free bulk water, right, that's not in a hydrogel with all that extra fluid in the interstitial fluid because of the excess of filtration. All right, we've got capillary exchange by diffusion. We've got capillary exchange by bulk flux. And the Starling equation describes that. And then we have our application by tweaking any one of those four. And we could even talk about changes in KF, if you will, right? Remember, that included surface area of capillaries. What if you had loss of capillaries? That happens. It's called microvascular rarefaction. You don't need to know that term, right? But if you lose capillaries, the surface area available for bulk flux or diffusion goes down, right? And so this part of the equation would go down, right? Which means bulk flux would go down, right? So again, we can change any one of these things, the Starling forces or the KF, the leakiness coefficient factor. All right.